To Geriatric Grand Rounds. A few announcements before we get started. So next Grand Rounds is going to be October 29th, and our speaker will be Dr. Peter Ubel. Dr. Ubel is a professor of business, public policy, and medicine at Duke University, and we'll be talking about out-of-pocket costs and poor medical care. Our next Journal Club will be November 12th, and our presenters will be Dr. Megan Gauss and Dr. Jeff Wallace, so please join us for that. A couple of other announcements. So for today's presentation, please feel free to submit any questions as we go along using the Q&A box at any time, and we'll get to those questions at the end of the presentation. After Grand Rounds today, you will receive an email with a link to the recording of the presentation as well as a copy of the slides. And that will also include a link to an online evaluation of the presentation. So if you would please be so kind as to fill that out, we would appreciate it. So I'm pleased to introduce our speaker this morning, Brecken Hentz. Dr. Hentz is a speech language pathologist. She's been practicing for 11 years. 7 years she worked at a Level 1 trauma center in North Carolina, where she was a senior clinician working with a wide variety of patients, and developed a strong relationship with the geriatrics department there, working on projects related to delirium and dementia. We were then lucky that she moved to Colorado to enjoy the mountains and has been at the Rocky Mountain Regional VA for 4 years, 2 of which she's been the lead speech pathologist. She works with patients across the continuum of care, but has a strong interest in dysphagia and aphasia at the end of life. So she's going to talk with us today about dysphagia management in the geriatric population. So welcome, Dr. Hentz.
Thank you. And you upgraded my status. I'm not a doctor, but thank you. So as she was saying, I have a strong interest in this population, the geriatric population and dysphagia at their end of life. When I started working at Duke Medical Center many years ago, I got stuck on the gen med floor, and I was like, oh, I want to be on the trauma floor. I want to be on the neuro floor, all this stuff. And then I ended up staying there the rest of my time there when I did acute care, because I really fell in love with the population and all the problem solving and just information you had to put together to decide what to do with this population. It wasn't nearly as cut and dry about diet recommendations and feeding tubes, and you had to take quality of life into consideration and all of those things. So that's why I kind of fell in love with the population. So we're going to talk a lot about those things today. Here are the objectives. We're going to spend the bulk of the time on presbyphagia and what just swallowing looks like at the end of life, or just when you're elderly in general. And then we'll talk about how we actually get aspiration pneumonia and some of the predictors of aspiration pneumonia. And then talking about modified diets, what evidence speech pathology as a whole has about our modified diets that we recommend. And then a little bit about PEG tubes at the end. However, I think the people attending this presentation probably know a lot of that information already. So we'll probably skim over that a little bit. First, I want to just start with some key terms, because I know when you look at a speech pathology note, it looks like Greek. We use weird terms that no one else uses. So I just want to go over this really quickly so that we'll have a level playing field this morning. So dysphagia is just difficulty swallowing, nothing more than that. There's three different types of dysphagia. There's oral, so in the mouth, pharyngeal, throat, and then esophageal dysphagia, which GI kind of holds that realm more than speech pathology. But we, as behavioral therapists, we do a lot of strategy development and behavioral changes and stuff with patients in regards to esophageal dysphagia, but it's not actually within our scope of practice to diagnose esophageal dysphagia. Aspiration is food getting into your lungs, right? The picture that you see there is gross aspiration. That's not what you'll usually see on the swallow study. Usually you'll see a very, very thin line that goes a little bit below the vocal cords, but I thought this was a very nice representation if you've never seen aspiration under fluoroscopy. Penetration, which you'll often see, is just when the food or liquid, the bolus, gets into the voice box or the larynx, but not quite past the vocal cords. So it can just be barely in, or it can be all the way to the vocal cords. We actually use a penetration aspiration scale of 1 to 8. So the 1 is no penetration or aspiration, the 8 is silent aspiration, so no cough response. And then again, silent aspiration is when the person aspirates and does not cough in response. And then pharyngeal residue is just leftover food or liquid in the throat. So it's when the bolus doesn't completely pass through. Few more terms. The word modified diet is a very loaded term because it can mean a whole host of different things. Diet terminology is not standardized, which you'll find as I go through this presentation is one of the reasons our research is kind of lacking in some areas, because we don't necessarily use standardized terms. That is changing. There's the International Dysphagia Diet Initiative, which is trying to get everybody in the entire world to use the same terminology. The VA has made it a priority to switch over to using that terminology, and the Rocky Mountain, we already use it here throughout Eastern Colorado. I think even our Pueblo CLC has it now. So the different diets range from pureed, it's completely pureed, all the way to regular, right? And then there's usually 2 levels in between, and those are just some of the names that they might come up with. We definitely use minced and moist because that's the International Dysphagia Diet terminology. You'll see most likely at other hospitals in the area, like dysphagia mechanically altered and dysphagia advanced, because that was a national standardization that was done a few, not sure exactly how long ago, but a while ago. And then we have our modified liquids, which range from regular, which I didn't put on the slide, all the way to some nursing homes and places use something called pudding thick or extremely thick, which is literally the same consistency as puree. I've never worked anywhere that uses that consistency because you can imagine the dehydration that could occur there, but some places have it. The one you'll see the most often is nectar thick or mildly thick, which is kind of the thickness of like a smoothie if it wouldn't melt, right? Like that's about what it is. Just in terms of what the swallow studies we do are, we do fluoroscopy. That's either called an MBSS or a VFSS, depending on where you are. Not to be confused with a barium swallow that the radiologist interprets and then GI kind of can make recommendations for. We can do endoscopic evaluations, so scope the patient and then they swallow while we're looking directly at the larynx. And then we have our clinical or bedside swallow where we watch the patient eat and drink from the outside, but also take into consideration their medical history and their goals of care and all that stuff to decide if we need further swallowing evaluation. Okay, now that we're through all of our crazy terms that we like to use, let's talk a little bit about what usually causes dysphagia. So any neurological impairment, dementia being one of them that's common in the geriatric population, respiratory diseases like COPD, the larynx actually doesn't want to close for long enough, so liquid often gets into the larynx and into the trachea that way. Intubation, just weakness from not using your muscles, head and neck cancer, deconditioning, and then I threw aging on here because it's kind of in the air of if aging itself really can cause dysphagia or if it's just changes, right? So the term for an aging swallow is presbyphagia, like anything else. This study by Ekberg was just 56 people, but with a mean age of 83. And you can see that only 16% had what we would call normal swallowing. And a lot of that was oral phase. The next highest was with the cricopharyngeal muscle, so the muscle between the pharynx and the esophagus gets hypertrophic or won't open as much, which we see a lot in people too. And then esophageal would be the third most common. Another study looked at 100 subjects who were 60 plus years old. They went to like a community center. So these were all people independently living, and their mean age was 73. You can see that a lot of them endorsed choking, coughing, and throat clearing, but not necessarily in conjunction with eating, which is kind of interesting to me. All 100 participants had a FEES, so that fiber optic view of the swallow. And you can see 39% of them had pharyngeal residue. They had that leftover food in the throat. This was a study done in another country, so they called them pasty foods, which I'm assuming is like our puree consistency. And then 26%, and then liquids less. And then 9% had laryngeal penetration, 6% had secretions just sitting within their pharynx or larynx, which is not supposed to be there. And then 2% actually aspirated. But the patients that aspirated and penetrated or had residue weren't really the ones that complained about this coughing and choking. There was really no relation. So there were these changes happening that we would call, a lot of people would call atypical, but there were no symptoms and no adverse effects of any of it. And then this Butler study, they actually only looked at 20 patients, but it was 560 total swallows. The mean age was 78.9. So there was actually laryngeal penetration on 15% of the swallows, with 75% of the patients participants, and then aspiration on 3% of the swallows, but 30% of the patients. So when you look at that many swallows over a course of time, this was also done via feeds because you can't do fluoroscopy for that long on a person. The machines start to yell at you after 5 minutes. Over that many swallows, this age group, a lot of them aspirated and most of them penetrated. So some of the changes just compiled from a bunch of research that I went through for this presentation. The main oral phase changes are oral increased time in the mouth. So they don't push the food back in their mouth as fast. They don't chew as fast. This is due because to weakness, but also because of dry mouth, poor dentition, those things. During the pharyngeal phase, they often had delayed, people in the geriatric population often have a delayed swallow. And I put delayed in quotes because swallow timing is variable per person and doesn't, even if your swallow triggers farther down in the pharynx than mine does, it doesn't necessarily mean it's disordered. It just started later. Reduced hyolaryngeal excursion, so the entire larynx has to close and move up and out of the way so your esophagus can open. So that is reduced, that movement is reduced. Increased aspiration and penetration. And then actually the larynx drops as you get older. So there's a bigger pharyngeal space, which means there you need more pressure to swallow. So the entire swallowing mechanism is a pressure system where your tongue base generates the pressure into your pharynx and then into your esophagus. So it requires more pressure to get the food through the pharynx, hence that increased residue that the studies were seeing. And then that also makes it where you have to swallow, you have to be not breathe for longer while you're swallowing because you've got to get all that space closed up. As in the esophagus, it's the most vulnerable, some of the research says. It's really interesting. I was getting conflicting information from the research on the esophagus as I was looking through it. That it used to be that they were like, definitely, the esophagus is affected by aging. And more recently, as they've started to look at comorbidities, it's more thought that comorbidities like diabetes and reflux and other things that can affect the nerves in the esophagus are actually more responsible for the esophageal dysfunction. However, that's more common in later in life. So regardless of if it's just aging or if it's comorbidities, we still see these issues at the later in life. So you have a longer time to clear your esophagus so this food doesn't go through as quickly. Reduce opening of that muscle at the top of the esophagus. Increased reflux, increased dysmotility, and increased achalasia. There's just reduced innervation of those nerves. And then the density of the striated muscles at the top of the esophagus. One study actually showed that those were atrophying as well. So then the peristalsis can't happen as well. And then again, other medical conditions. So what's the significance of this? So we see these changes, but the research is showing that people aren't really bothered by it. So why does this matter? The biggest reason is it creates a worse reserve when you are hospitalized. So a 75-year-old who's intubated for 2 days is going to end up with dysphagia for longer than a 25-year-old that's intubated for 2 days, let's say, right? So it can start adding, or a patient that's been in the hospital 5 times over the last 2 years is going to have a lot more, might end up with swallowing from deconditioning, whereas they wouldn't have if they were 55, right? Another big one that I often, it's really hard for us in the field is when you have an 89-year-old that does have a neurological event. So we have an 89-year-old admitted to rehab with a stroke. We do a swallow study and we're like, what's normal for him? What's new from the stroke? Like if they're aspirating, maybe he was aspirating before and it's not going to affect him, or maybe that aspiration is new and he is going to get a pneumonia from it. So it becomes this kind of guessing game about trying to figure out what was going on before and after. And then these normal changes can be bothersome to some people, you know, like if your sensation's intact and you've got a bunch of food left in your throat, that's going to be annoying. Or it could be undetected and no one really have a problem with it. So what do we do to treat presbyphagia? There's no magic line where we as speech pathologists say, I'm treating this, but I'm not going to treat that because it's normal aging. So we kind of look at it like we do with our voice patients. So presbylarynx is also a big issue in this population, where we all hear voice changes as someone gets older. Everyone's voice changes, men and women, as they get older. We don't always treat that because it's normal, but we do treat it sometimes when it becomes bothersome to the patients. They can't be heard, or they think they sound funny, or anything like that. So same thing with presbyphagia is If the symptoms are bothersome to the patient and it's it's reducing quality of life, especially if there's weight loss, and then especially if someone has pneumonias. So it's kind of doing the swallow study or talking to the patient and finding out how much does this bother them. So we try to use a lot of validated questionnaires and stuff, especially in this population. So there's one called the Eat 10 that asks a series of 10 questions about the swallowing, and then you get like this number at the end. So how much do they think that their swallowing is impacted, rather than how much do I think that their swallowing is impacted? And then how do you treat dysphagia? Just a quick plug for the profession as a whole, because I know it's kind of confusing. You can really visualize how a physical therapist is going to help someone. Our field is much harder to kind of conceptualize. So there's traditional swallowing exercises where the patient swallows in a different way in order to strengthen the muscles. So one that's just quick and easy to show you guys is called the Masako maneuver, but it's to help with base of tongue retraction. So like I was saying, the base of tongue creates that pressure that makes food pass through the pharynx into the esophagus. So for this exercise, you literally just stick your tongue out and swallow with your tongue sticking out. So you kind of use your teeth as a resistance band to make it harder for that tongue to go back. It has to work harder and make the tongue meet your pharyngeal wall. Just a random, one of the many that we have. There's expiratory muscle strength training, which is a device you blow on that helps with cough strength to get any aspirated material out, but has also been shown to improve laryngeal closure. There's the IOP is a device to help strengthen the tongue as well. And then there's also compensatory strategies like diet modifications, which we'll talk about in detail in a second, and then compensatory swallowing maneuvers. So the dreaded chin tuck that everyone's probably seen or heard of, what that's really meant to do is for someone that does have a slow to start swallow or delayed swallow, when you tuck your chin, your vollecular space gets bigger so the bolus can hang out there while your swallow initiates. The chin tuck works for like 6% of the people you try it on. So it's really not the game changer that we all hope that it is. Head turns close off the weak side, so everything goes down the correct side, the stronger side if it's unilateral issues. A double swallow clears that residue in the throat. A breath hold can actually close your voice box up better so that food and liquid can't get in. And then alternating liquids and solids can also help with clearing that residue. So I threw a few cases throughout to kind of highlight what we're talking about, because I know it gets boring just to hear me drone on about research. So if we look at these two patients, they're relatively the same age, in their early 90s. Neither one has had pneumonia. The first one on the left complains of food sticking in his throat, but he's able to wash it down. He's referred because his daughter's concerned because he's drinking more liquids while he's eating. He's taking a little longer to eat, and she was concerned. The swallow study shows that the pharyngeal residue he has pharyngeal residue. It's kind of cleared by food liquid, but it's not always all the way cleared. Our second gentleman on the right side of the screen complains of food getting stuck. He self-referred because he was annoyed by it. The swallow study showed that there is pharyngeal residue that's kind of cleared again, and actually one instance of trace aspiration that we couldn't repeat. So he swallowed once, aspirated, swallowed a bunch of other times, never could repeat it. So in this case, the gentleman on the left, probably not going to treat it. We'll talk to his daughter and him about, you know, this is pretty normal. If this gets worse and becomes bothersome, come back and we'll give you some exercises. It probably won't get any worse, right? But the gentleman on the right, he's already bothered by it. His EAT-10 score is going to be higher. He is motivated. So let's treat it. Let's get rid of this problem for him. So we'll do specific exercises to work on whatever's causing that residue. And then we probably won't even treat the aspiration. I mean, if he's really motivated, we could throw in an exercise for laryngeal closure, but that's not his complaint. And we know that healthy 92-year-olds are probably going to aspirate some of the time. Oops, sorry, my slide didn't turn. There we go. Okay, so switching gears to aspiration pneumonia. So we have our elderly population. They may be aspirating sometimes. When they're hospitalized, they may have worse issues with dysphagia that do become an issue. So when do we start to modify those diets? Why do we modify them? And what truly contributes to aspiration pneumonia? Because we all know that everyone, or I know that everyone that aspirates does not get pneumonia. And it's really hard to determine sometimes if someone will get it and someone who will not. So the study that speech pathology in general looks back to is actually one from 1998, which is a long time ago, but it's actually a great study and it has held the test of time. Clinically, we all see these things playing out, and it's been repeated a couple of times where the results have been similar. So it was 189 patients across the continuum of care. They all got a whole bunch of swallow workup that you can see there. They all they had chest x-rays and white blood counts, cell counts, and all that stuff to determine if they got aspiration pneumonia. And 41 of the 189 patients did develop an aspiration pneumonia. So almost 22% of them did. This list is the predictors that came from that. So they looked at a whole bunch of different factors that they could judge in these patients. And the predictors of which patients got aspiration pneumonia or developed aspiration pneumonia were these. Being dependent for oral care being the number one predictor for aspiration pneumonia. Being tube fed, which is interesting because we're placing feeding tubes to prevent aspiration pneumonia, but they don't. Being dependent for feeding, being on a lot of medications, being a smoker, having a lot of medical diagnosis, and decaying teeth. You notice that dysphagia is not on this list. Quite a few of the patients did have dysphagia. I think it's on the next and one of the slides later, but like 80% of the patients that developed aspiration pneumonia did have documented dysphagia. However, it wasn't one of the main predictors. And then by setting, I kind of broke it down for you guys, which makes sense, outpatient versus inpatient versus nursing home, with the highly significant association, again, being a dependency on other people for something, in this case, for feeding, which is really interesting. So the incidence of pneumonia by setting, of course, the nursing home population had the most pneumonia. They're the frailest. That makes sense to all of us. And again, 81% did have some kind of dysphagia. So if you look at how we develop pneumonia, aspiration pneumonia specifically, and all of the predictors of aspiration pneumonia, first we have to have colonization. So being dependent for oral care is having decayed teeth. That makes sense, right? You have bacteria in your mouth then, right? Because if you're dependent for oral care, maybe they're not brushing as well as they should be or as often as they should be. And then xerostomia causes more bacteria. So if you're on a bunch of medications that are causing that, or if you're on tube feeds, you're not eating by mouth. And so then you have all this extra bacteria in your mouth. And then with your aspiration into the lungs, being dependent for feeding, if someone's in a rush and feeding you quickly or giving you bigger bites than you can take, that kind of thing, then that's going to cause aspiration. And then host resistance. If you're smoking, you're going to have poor pulmonary clearance. And then just a poor immune system, if you have a bunch of medical diagnoses. And then that's how you get your pneumonia. So what do we do about it? So we know someone has dysphagia. We're going to talk a little bit later about modifying diets. Spoiler alert, modifying diets isn't always the best thing to do. So what can we do to manage these other predictors of aspiration pneumonia? So if someone's dependent for oral care, we need to talk to the facility they live in their families about why oral care is so important, how to do oral care, those kinds of things. Electric toothbrushes can be very, very helpful if someone can't do their own oral care, because then you kind of does the work for you, right? If the patient's tube fed, we need to make sure that head of bed is elevated. We know that people that are tube fed do reflux more often because you're being fed an abnormal way. And then if they're getting pneumonias being tube fed, should they just be eating instead? Maybe we need to look at that and which one's going to be safer, or at least provide better quality of life. Being dependent for therapy, our occupational therapy friends have a bunch of fun adaptive equipment that can help someone feed themselves for longer, right? It's not going to be, they can't fix everything, but if someone has a trimmer, they can do weighted spoons. They have built up edged plates and all kinds of fancy things. And then caregiver training and how to feed somebody. I think the best way that I do this when I do like training at our CLC or somewhere is I make CNAs or nurses feed each other. So what does that look like? How does that feel? Okay, now go fast. Okay, now don't ever give them a liquid. You know, like what does that feel like? What does that look like? And that can often be a really good way to show someone what they need to do. Medications, let's make sure that all the medications are needed. If there's an alternative to a medication that's really causing dry mouth, can we do that? education on smoking, of course, managing all the medical diagnoses, especially any respiratory diseases like COPD, emphysema, those kinds of things. And then if they have a lot of decayed teeth, they need to go to a dentist. If they have dysphagia and decayed teeth, dental should be the #1 priority. So in summary, this is a quote from Langmore herself. Aspiration pneumonia is a multifactorial phenomenon, and no single predictor can cause the disease. A major conclusion was that dysphagia and aspiration are necessary, but not sufficient for development of pneumonia. So we have to all keep this in the back of our heads when we see aspiration, when we hear that a patient's aspirating, and not freak out that they're aspirating, but look at the whole person and see how likely it is for them to get pneumonia. I wish there was a formula to make my job easier. So I have a few cases to look at. Which patient's more likely to get pneumonia? Not the best game to play, right? So the first patient's 70, he has newly diagnosed laryngeal cancer. No treatment plan has been made at this time. He doesn't have a lot of comorbidities. He's very functional. He's still working. His modified showed laryngeal penetration and aspiration with everything. So thin liquids, thickened liquids, puree, solids, everything had a little bit of something going on. Our other gentleman on the other side is much thicker at baseline. He has COPD, which is actually how he got to the hospital, was from his COPD, and then they found the laryngeal cancer. He's been losing weight. He has rotting teeth. He has to walk with a walker. And his swallow study showed the same thing. So gentleman on the left is going to keep eating until his cancer diagnosis. He may need a PEG tube during cancer treatment because radiation is heck for pain and all that stuff, and you don't want him to start losing weight. So he'll probably end up with a PEG tube at some point, but he's going to eat through the whole process. He's never going to stop eating. He needs to eat, and his aspiration pneumonia risk is low. We're going to monitor it, but it's low. The gentleman on the right may need to be made NPO, at least until his COPD exacerbation resolves, and then we start back slowly with a lot of monitoring, right? He's probably going to need to go ahead and get a PEG tube now because we're not going to want him eating quite as much throughout his cancer treatment. These are two gentlemen from our CLC in Pueblo. For those of you who are not in the VA, that's just the VA's term for a nursing home or a SNF. It's a community living center. So the gentleman on the left has severe dementia and is wheelchair bound. He's been on a modified diet for at least 8 years. I can't find back in his chart when he hasn't been on a modified diet. He's actually on puree and moderately thick or honey thick liquids, which is very thick, as thick as honey, which is why it's termed that. He has coughing and wetness during every meal. The gentleman on the right is a little bit younger. He has schizophrenia, some medication-induced Parkinson's, and now dementia. He's had a pretty significant decline over the last few years since I met him. He has a modified diet secondary to coughing with thin liquids. He hasn't had a swallow study in several, probably about 5 years. I can't remember exactly how long. He's on a soft and bite-sized diet with mildly thick liquids. And I left this off the slide. Sorry, guys. He has had 3 pneumonias in the past year and a half. So this one's not what you would expect, right? The younger gentleman is getting the pneumonias. The older gentleman who's been on a modified diet forever isn't. So there's no clear picture about who's going to get it. The thing that makes me worried when I look at these, if I didn't know these guys, is the significant decline over the past few years. So his body is now getting more used to aspirating. So the gentleman on the left, the 80-year-old, he's been aspirating the same for at least 8 years probably. His body is used to it. His immune system is used to it. The gentleman on the right is having this significant decline right now, and his body is adapting to that. So we're actually doing a swallow study next week on the guy on the right to kind of figure out. His guardian decided, so let's work it up and see how bad the swelling is, and then we'll make our decisions about whether he's going to continue his modified diet, go back to a regular diet, further modify, that kind of thing. So just a case that's going on now. And then 2 gentlemen with Parkinson's disease. One has COPD and a lot of pneumonias again. He's also wheelchair bound. The other gentleman teaches karate still. So of course, the gentleman that teaches karate still is going to tolerate that aspiration a lot better than the gentleman in the wheelchair, right? He's not up and moving around quite as much. So the gentleman on the right, we would probably, because it looks like from his swallow study, he does well with the mildly thick liquids or the nectar thick liquids. So we're probably going to try that out, see how he does with it. Make sure he's not getting dehydrated, all those kinds of things as we do it. The other gentleman are probably going to let us keep drinking thin liquids, just with a lot of education about respiratory illnesses. So then what do we do? So we have a patient like the gentleman on the right back there. We are kind of concerned that he's going to get an aspiration pneumonia. He's already been having pneumonias, whatever. So there's two options, right? There's modified diets, which I'm going to go into a lot of detail about, and then there's feeding tubes, which I think we all probably have opinions about in this population. So modified diets, I am going to tell you there's not a lot of evidence. And the biggest reason is if we know someone's grossly aspirating something, is it ethical in a research study to ignore that? And so it's been really hard to compile the evidence. I think that speech pathology is doing a much better job of getting good evidence in the past 10 years or so than we used to have, but this is still one area that's going to be really hard to research. And like we just showed, it's so multifactorial that how do you really tease all of that out, right? So this first study by Murray, it's a lit review. So look through a whole bunch of articles. The results, we all know, and this is pretty good fact, that the thicker a liquid is, the less likely you are to aspirate it. It moves slower through the pharynx. You have time to close the larynx. It works, right? But several studies do show, and I see this clinically, that the thicker a liquid is, the more residue you're going to have from it. So then that makes determining a safe diet very complicated. For solids, we lack evidence for modifying solids, to tell you the truth. One of the reasons is because of the poor terminology, like my soft solid doesn't equal your soft solid. There's a couple studies from there's a Japanese study, interestingly enough, that showed that sticky rice cakes were found to lead to choking accidents more than jelly cups, which I'm not really sure what a jelly cup is, but I'm assuming it's softer, right? But those jelly cups did still cause some choking. So yeah. But then the flip side of this is that choking on something solid is going to lead to an actual choking episode that could cause death or need the Heimlich maneuver, right? If you can't chew up a large piece of solid, it's going to obstruct your airway. So we know there's a safety risk, but it's hard to decide at what point, right? So our clinical rationale for solid diet modification, hard solids are more difficult to chew. So if it could cause airway obstruction, like we talked about. If there's reduced strength, there could be fatigue with something harder. If there are respiratory issues, chewing can be taxing. And so then your respiratory rate increases, and we can watch that on the monitors. And then that swallow apnea is going to become harder. So there's some clinical ways that we can kind of decide. I do think that peri diets are probably overused though. Another study by Robbins. This one's really interesting. So they took patients that equally aspirated when aspirator penetrated thin liquids with a chin tuck, and thin nectar thick liquids or mildly thick liquids. Sorry guys, I hate that there's two names for every liquid, but everyone's in the transition between the two, so I don't know which ones everyone's familiar with. So everyone was put into three groups then. So this group of people drank thin liquids even though they were aspirating them. This group drank, I'm just in that completely wrong. I'm sorry, it was a chin tuck down, nectar thick liquids, and honey thick liquids. I apologize. So chin tuck with thin liquids, even though you're aspirating them, but you're also aspirating nectar and honey. Then we do nectar thick liquids only and honey thick liquids only. So the patients who are randomized to the chin tuck group were least likely to get pneumonia. So when someone is aspirating everything, we want to leave them on thin liquids probably. Now they were given cues to use that chin tucks, so like most of our people are not going to have those cues. And patients who were in the thick and liquid group were more likely to be diagnosed with dehydration, UTI, and fever as well. So when all things are equal on a swallow study, we don't want to put a patient on honey thick liquids just because maybe they're aspirating it a little less. Maybe over the course of the meal, less will get in their lungs. But our research shows us that thin liquids are going to result in fewer complications. So adverse effects, we just started talking about those of modified diets, poor nutrition and hydration, delayed medication absorption actually, which was in a study that I looked at. So if you're taking meds with something that's really fixed, some medication absorption is actually affected by that. Impact on quality of life, of course. I mean, can you go out to a restaurant and bring your thickening packet with you? Like, not that we go to restaurants right now, but most of the time, can you do those kinds of things? At Thanksgiving, you're eating a pureed diet and everyone else isn't. That's not fun, right? Caregiver perception, and then cost. Thickener is expensive, especially the good ones. There's two kinds. There's powder, which gets clumpy and thickens up over time and is kind of gross. And then there's the xanthan gum version, which is much more palatable, but it can get really, really expensive. So I talked about this a little bit already. There's a lot of limitations of our research, ethical issues being the biggest one, lack of standardized terminology, and then a lot of the studies didn't look at actual compliance. So I looked at recommendations, but it's really hard to know actual compliance with different diet recommendations. Because I can tell you, most of our patients don't comply. And as we look at all this, you can kind of see why, because of all the different effects that it can have. Sorry, I was looking at my time. So that being said, the incidence of modified diets in nursing homes, thickened liquids are used in up to 25% of long-term care residents. So does this fit with our literature? And I would say no, it does not. So our own, just to think about like a place that does take an interdisciplinary approach to this population, we have our CLC in Pueblo. Has 22 patients. They're all very complicated. These are very complicated patients with a lot of psych issues, very frail. Only 4 of the 22 are on a modified diet, which is only 18% of that population. And that, you know, so if you think about it, like that seems more realistic given the research that we're looking at. And our acute care hospital here usually runs about 2 to 5 patients that are on modified diets at any given time. It's going to be a lot higher because if you're acutely ill, it makes more sense to modify a diet temporarily so you can get over your medical condition and then go back to eating something normally that's safe. So what do? We have to use our clinical expertise. We have to talk to the team. Palliative care is always an excellent resource in these conversations, and geriatric physicians. We have to think about our predictors of aspiration pneumonia. How many of those predictors do they have? Okay, now let's think about which is safest. And then we have to monitor this patient status and having ongoing discussions. Maybe someone is eating with known aspiration risk for 10 years. Then they start developing pneumonias. Well, maybe we need to change our plan. And maybe they go 5 years without getting pneumonia. Maybe we change our plan again, right? So should we modify the diet? We have a 69-year-old chronically ill patient who's actually in our hospital right now. He's been hospitalized many, many times over the last 2 years. He's admitted with a whole host of things that you can read there. His full prognosis is pretty poor, but he's full code per his family's wishes. His chest x-ray shows bilateral pleural effusions and right lower lobe infiltrates. So we know infiltrates, that kind of screams aspiration pneumonia. If, you know, like we start to think about aspiration, if there's infiltrates. He's requiring 2 liters of oxygen. I need to change that. He's actually, okay, we'll take him at this point in his stay. He's actually in the ICU right now. He has overt tracheal and pharyngeal secretion. Some of you have ever listened to the person that like you can just hear the wetness in here, right? That's usually not a good sign. That means you're not clearing your saliva, right? Or you have lung secretions that you're not getting out, or both. Clinical swallow evaluations show coughing with thin liquids that was very consistent. It increased that wet sounding junk in the throat. It's a very technical term. And this was eliminated with our nectar or mildly thick liquid. So what do? So we modified his diet. I did. I was the one that saw him because it was kind of scary. You know, this guy's full code. He's not doing great and he sounds pretty bad. A few days later, he was crying because he couldn't have thin liquids. So the team talked to the family and they decided to upgrade. He went to the ICU with worsening respiratory status. Who knows if aspiration is the cause? He has pleural effusions as well. He has a whole host of other issues. So this guy's kind of going back and forth between modified versus not modified diet based on his exam, his clinical picture, and then his family wishes and his wishes. So he's been very complicated, but kind of gives you a picture of all the thought that has to go into everything. Another 69-year-old, he's on a rehab unit, so he's already out of acute care. He's been cleared that, he's pretty stable. He's had his basal ganglia stroke for two weeks ago. He's healthy otherwise, his chest x-ray is clear. Prior to the stroke, he was independent and working. Right now he's requiring assistance though for transfers and walking. His swallow show study, so he's NPO at the time of the swallow study because his previous swallow study looked bad. He has a Dobhoff tube in now. His new swallow study's borderline. This is a 69-year-old, so we expect his swallow to look pretty normal at baseline, maybe a little extra pharyngeal residue, maybe a little laryngeal penetration, but not much more than that. So he had thin liquids went to the vocal cords. He penetrated those to the vocal cords, but it didn't go into his trachea or his lungs. He had a lot of residue with thicker things. The liquid bolus, thin liquids, cleared that, but still caused that penetration. Thickened liquids didn't clear the residue, or didn't penetrate, but didn't clear the residue either. So our fluoroscopy time is 5 minutes. We can have this fluoroscopy on for 5 minutes until we have to shut it off because of that radiation exposure. So you don't really have a lot of time to watch. You can't like watch a patient eat a whole meal, right? With a fees, you can watch more, but there's a scope in someone's nose, so who's gonna let you keep a scope in their nose for a 30-minute meal? I can tell you I wouldn't. So our studies are limited. So will this guy do better with thin liquids that we know he's penetrating all the time, or thickened liquids with building up residue? So the residue is building up in his throat and could eventually cause aspiration. Or do we keep him in PO because that's safest, but then how are his muscles going to keep recovering if he's not using them, right? I put this in a presentation a long time ago, so I can't actually remember which one we did, but there's 3 choices there, right? And so you talk to the patient, you talk to the team, and you kind of think through it. This guy's in the hospital setting, so we can monitor him really closely. So we probably put him on a diet. We probably put him on the thin liquid diet, to tell you the truth, and just have him cough every few bites if he can remember to do that, those kinds of things, and then monitor really closely. So we want to get him eating because that's going to help his swallow keep recovering. We have a nursing home resident with dementia, no lung disease. He's not had pneumonia, silent aspiration of thin liquids. He was on thickened liquids though at an outside hospital, hated them, wouldn't drink them. We're not going to put this guy on thickened liquids. One more guy though, very similar, has dementia. He's had a bunch of UTIs over the last 6 months. His wife can't get him to drink enough. He drinks thin liquids until he starts coughing his head off. It's uncomfortable, so he stops. So we do an eval, we try the thickened liquids out. He drinks it. He doesn't cough. He keeps drinking it. He doesn't really seem fazed by the thickness. So we're going to try that out with him then. So we never did a swallow study, but we know one makes him more comfortable. He still could be penetrating it. He still could be aspirating it silently just because it's a smaller quantity. But we're going to go ahead and try that because it's going to be more comfortable. And in this case, the thickened liquids might help with the UTIs, which is counterintuitive to the research, right? I'm not, because there's not much time left, and I want to make sure I can answer your guys' any questions people have. I think that the people attending this presentation know a lot about feeding tubes, so I'm going to go through this very quickly and then leave time for questions. Biggest thing about feeding tubes is it doesn't prevent aspiration. So we saw from the predictors of aspiration pneumonia that having a feeding tube actually is one of the biggest predictors of getting aspiration pneumonia. Now, someone with a feeding tube is going to be more frail. They're going to have more comorbidities and that kind of thing too. And the reasons for that is you still aspirate your secretions. You have more bacteria in your mouth if you're not eating at all because of xerostomia. And then you aspirate reflux, so stuff comes back up. And we talked about earlier with the esophagus and the elderly population specifically, if the esophagus isn't working as well, and now we're introducing food directly into the stomach, they're likely going to reflux more than they did at baseline and then have those issues. You know, I've seen people have a feeding tube placed and then they become more wet sounding out right after their feeding tubes are given because everything's kind of coming back up, right? There is evidence on specific populations. Dementia, of course, we do not recommend feeding tubes for. We want to do careful hand feeding. We want to involve the entire multidisciplinary team in that decision. But then there's actually evidence for feeding tubes with ALS in particular, depending on the patient's wishes, and then for head and neck cancer patients as well. They often do better if they have a PEG tube, if they need one. So I have this in here, which most of you are likely familiar with. It's the thing that I go back to when I'm dealing with a difficult family with feeding tube placement and dementia. The geriatric position statement on feeding tubes and dementia is excellent. The biggest things out of it that I always like to remember is how many people with dementia actually get feeding tubes, because I am lucky enough not to see that here very often at all where I work, but I know that it happens in the community too very often. So making sure that we really have those long discussions with family before an incident happens, so we know what their plans are. So anyone in the earlier stage, like probably not when they first get dementia, that gets a little scary, right? But when you're getting into the moderate stages of dementia, let's make sure that families know what they want to do. And let's actually make sure the patient told us when he still could. Does he want a feeding tube when this gets worse or not? That's the number one way to make it easy. If families that I work with who know that their family member never wanted a feeding tube can make this decision so much more easily, because caregivers see it as, well, if I don't, then they're going to drown. They're going to be starving. We all know how we feel when we're hungry. So they get these ideas in their head that they're neglecting or abusing their loved one, right? So if we have these conversations early on and normalize this process, it can be really, really helpful. So we're not recommending feeding tubes. We want careful hand feeding. I'm not going to read all of these to you, but they're going to send you the slides. So if you're not familiar with this position statement, I would read it, or at least read through the slides. I did spend a little time putting in here what careful hand feeding looks like, because it's like all these things say, let's feed the patient carefully. Well, what does that mean, right? So when you set up a meal for a patient who cannot feed himself or herself, we want the patient sitting as upright as possible. That makes sense. We want the person feeding the patient to be within view of the patient. We don't want peripheral out here. It's really scary to have a spoon coming at you that you don't see the person, right? So with dementia especially, our field of view narrows, so you don't want this random spoon or fork coming at you. It's kind of scary. Make sure food's appropriate temperature. We all get in a rush and the tray's been sitting there forever and we don't heat it back up. We want things to be as normal as possible, right? We want to limit distractions so the patient can focus on eating. And then we want to monitor alertness and feed the patient when they like to be fed, right? So if a patient's sleepy early in the morning, we're going to hold their breakfast till 10, kind of push back their other meals. I know that gets really complicated in facilities, but we're going to do the best that we can. And then when you're actually feeding the patient, smaller bites and smaller sips than you would take, because we're always in a rush and eating too fast. Make sure the patient has swallowed before providing another bite or sip, so you can watch and make sure that the Adam's apple goes up and down. They've swallowed. We're going to check inside their mouth. When you're putting the next bite in, you can kind of take a little peek and see if the food's gone from before, right? So you don't have to do anything abnormal, but you're just kind of spending some extra time. You're going to go slowly. You're going to listen for that gurgle we were just talking about and try to get the patient to cough and clear that. If it's bad enough, we're going to suction their mouth and try to suction as far back as they'll let us and try to get some of that gunk out before we continue. Yeah, so it's pretty simple, but you have to kind of think about it, right? And like I said, this is the research on ALS and head and neck cancer. I think the biggest debate in head and neck cancer is just when to place the feeding tube, if we do it before the treatment or after the treatment starts, only if they need it. So our last couple cases, we have an 82-year-old male who, this is another CLC resident who passed recently. He has dysphagia and drooling that's worsened, a correlated functional decline. He's not walking anymore. His speech is almost unintelligible. He's more confused. He's not talking as much. He's admitted to an outside facility with his first pneumonia in several years. He was treated without an ICU stay. He unfortunately had a swallow study, even though I know that he was aspirating and had been for a few months at least, probably many years. The SLP was not familiar with him. She saw a bunch of aspiration. It looked scary. She recommended he be NPO. When we just recommend NPO, then that puts the medical team in a real funny position if they don't have all the skills that some, if they don't, it puts them in a weird position because the SLP is saying NPO, and then now I want to contradict that, and it's kind of funny. So luckily, this patient didn't end up with a feeding tube. His brother actually felt a little bullied into getting a feeding tube because he had always said, the patient said I didn't want a feeding tube. The brother was really clear with that. I talked to them, the medical team at the facility, the VA facility had talked to him a lot. But then he actually felt a little bullied after all this went down inside the hospital. He actually ended up not being able to have it because of a GI abnormality when they tried to place it, luckily, because no one actually wanted it. So this just goes to show that when you don't know the patient well, you can get put in sticky situations, right? And so the thing that I usually do with swallow studies, and if you work with speech pathologists, you can kind of ask for or discuss how to best do this. We usually will give 3 options for patients like this. We'll give, let's not modify anything, let them keep going. Let's modify the diet this way, which makes it a little bit safer. Or let's do NPO, which we're not going to recommend because of the dementia, right? Or not even give that option. You know, like the position statement from the geriatric position statement has made it where we don't really necessarily need that option unless someone's getting like a lot of pneumonias and that kind of thing. Like, we're going to say that eating is the best thing. We know that eating something is the best thing for this patient. Should we go all out, or should we modify it so he's not coughing as much, right? This next person is a little bit younger. He had an ACDF that caused a significant narrowing in his pharynx to make swallowing very complicated. He's still working. He has somehow maintained his weight, which is just a miracle considering how much food sticks in his throat on the swallow study. He has significant stress and anxiety about eating, panic attacks. He's been working with a psychologist, and significantly reduced quality of life because of it. So this gentleman, he's going to keep eating what he can, but he's also going to get a feeding tube because that's going to help with his stress and anxiety. That's going to make it where he can eat what he wants and not have to rely on that, right? Oh, I did a lot. This is the last one, I promise. This is a guy with COPD. He's having an exacerbation, so he's admitted. He incidentally found a laryngopharyngeal mass. He does not have stable housing. He has possible cognitive impairments, no medical power of attorney. We have a lot of questions surrounding his capacity. The swallow study showed that the safest diet is soft, like soft and bite-sized, I left out a word, sorry, with our honey thick or moderately thick liquids. Given the pharyngeal residue, he may aspirate this. Though our concern with a feeding tube is infection risk if he's not going to a stable place to live. He also doesn't really have the cognitive capacity to kind of work this up, right? Or to kind of make this decision. So what do we do in this case? This is also one that I used from a different presentation, but I think we ended up going with the PO diet and watching him because we did see that it was relatively safe, right? And then while his cancer got worked up, and they decided if there was a treatment plan or if hospice was going to be the best idea, right? And then I listed all my references out if anyone's interested in any of the articles that I cited. All right, what questions does everybody have? All right, the first one, I have had several patients who were NPO for dysphagia. However, the team says that the patient can still take pills. Number one, how severe does dysphagia have to be before we move all oral meds to liquids? And how severe does dysphagia have to be before we have no oral medications at all? That is a great question. So if someone's NPO and can still take meds, a lot of times it depends on, and I don't know what setting this person works in. So if it's like in acute care, and we want to keep the patient NPO, but we know that they have important medications that need to be taken, we'll sometimes sacrifice a little bit of aspiration to get those meds in them because we know those are going to be safer. So if I have a Parkinson's patient that's admitted, I don't want him to stop taking his Cinemet. That can't be put in IV, it can't be crushed. So we're going to find a way for them to take their meds no matter how bad their dysphagia is, because we know that if he goes off of his meds, everything's just going to get worse, right? If it's someone at home that's taking their meds, they may be doing some pleasure feeds of certain consistencies. So we're letting them take their medication that way too, because meds can stop up feeding tubes and make it really complicated. And that's one of the main reasons people end up in the ER with clogged feeding tubes is because they didn't crush the meds well enough. So if there's any safe or safe-ish way to take your medications, we like people to be able to, just because of the complications that can happen. And again, and how severe does it have to be? It's really a mixed bag again. Like, we don't want the patient to aspirate a pill. So if they're aspirating solids or puree, we're probably not going to let them have PO meds, but they're just aspirating liquids and like penetrating puree or have residue with puree, then maybe we're going to let them keep taking oral meds. I hope that answered your question. Ask a follow-up though if it did not. Any other questions for me?
Brecken, there's another question in the in the Q&A box, which is, are there data to support the use of chlorhexidine rinse to improve oral bacterial load and reduce the risk of aspiration pneumonia?
That's an excellent question. I do not know the answer to that, but that's a great thing to look up. I do know that the research shows that for oral bacteria, the friction from a toothbrush is the best thing. So the absolute best thing is a toothbrush and toothpaste, no swabs or anything like that, because you want the friction, but I don't know about that rinse specifically. But anything to get rid of the bacteria, in my opinion. And I can't apparently see all of the questions for some reason.
Okay.
So if there's more, let me know. Sorry, I don't know where they went.
Yeah, there's another one.
Oh, there they are.
Yeah, how much therapy does it usually take to see improvement?
That's another loaded question. It really depends on the patient. But we usually say, so if you want to see actual muscular change, you need like a lot of therapy, right? So we usually say 6 weeks is minimum to see any actual physiological improvement. Now you're going to get that functional improvement where people are like, oh, it's so much better. And a lot of times that is placebo because they're doing something about it, or it's that they're swallowing more safely because we've given them strategies. But 6 to 12 weeks usually. And then after 12 weeks, if we're not seeing improvement, we're going to either say, we're not going to make this better, or we're going to rethink our plan and maybe try a different set of exercises, or if we see just a little improvement, up the repetitions, that kind of thing. So it's very hit or miss. They do work though, amazingly enough. Dysphagia exercises work really, really well, especially in certain populations like stroke, head and neck cancer. But even for just elderly, that's a bad way to say that, but for the elderly population, I have seen people have significant improvements. I many years ago treated this guy who had no other diagnoses. We think he probably had dementia and kind of sent him on to neuro or the geriatric clinic at Duke to kind of figure out, because there were some red flags. But he came in, he was completely independent, traveled to Europe with one of his community groups, but had to stop going because he choked so badly. And he came in and he aspirated purees and solids, and like never had a pneumonia, but he was like, and it was completely silent, gross aspiration. Like you guys would all see the aspiration, even if you've never seen a swallow study, it was that bad. And he did therapy and it improved. I don't think it got back to normal. I can't really remember, but it did improve. And even without some neurological diagnosis, event that had caused his dysphagia, the exercises did work. Any other questions?
There's another one, kind of a nice segue with that. Are there data to suggest we should be prescribing prophylactic exercises for patients who may be at risk?
That is a great question. And when I was looking through the research, no. And a lot of the studies said that's the next step, right? Do we do these prophylactics? So if we find out someone does have presbyphagia, do we go ahead and do them? The biggest issue with that is it's resources. One, like, are we going to put everyone under fluoroscopy or endoscopy to find out their particular deficits? Because we don't usually just do blanket exercises. And then like if nothing's, so it's kind of hard to decide, but I would like to see, I couldn't find an article where someone had done prophylactic and kind of seen if it improved the pharyngeal phase of the swallow. So yeah. Anything else?
I think that's it. So thank you again so much for a wonderful presentation. Thanks to everyone for participating, and please check your email for evaluation and links to the recording and the slides. So, Brecken, thank you so much. That was a great presentation.
Thank you very much. I'm happy to do it.